We're live.
All right, welcome back. This is the Child Protection Oversight, Legislative Child Protection Oversight Committee. And we are continuing our discussion from this morning where we have Deputy Commissioner Erica Radke here with us, who's been doing a great deal of work today with us, and we appreciate that. So, Deputy Commissioner Radke, we asked for an overview of services and programs in the division, and then with an eye to understanding what the needs are and perhaps where we might have some needs or where the gaps might exist. So thank you for being here. And is this your screen that we're looking at? Deputy Commissioner Radke, are you there?
Yes, it is. I'm sorry about that.
That's great. Okay. So why don't you go ahead?
Okay, great. Thank you. Thought we would do sort of an overview of our services and what our mission is at FSD. So I'll move on to the first slide. The first slide provides FSD's mission. Our primary focus as a division is, of course, child safety and law abidance for youths and emerging adults. Our preference is to achieve that goal while keeping the child in the home with the family, which is, of course, much less intrusive and disruptive for both the parent and the child. However, if that's not possible, the child may need to come into DCF custody, generally under foster care or kinship care, or under a conditional custody arrangement in order to be safe. While at the same time, parents are offered supports and services, all with the ultimate goal of reunification. In the event that reunification isn't possible, our division works to find permanency, safety, and security, things all children deserve, through options such as adoption or guardianship. The four key outcomes that undergird our mission are safety, permanence, well-being, and law abidance. And it's important to note that while this is FSD's mission, we in no way accomplish it all on our own. We engage and work with right alongside family, foster parents, partner agencies, and the community to achieve the best outcomes we can for the children and youth in our custody. The structure of our division is pretty straightforward. There are 12 district offices located throughout the state, which serve as the base of operations for the family services workers. There are 2 statewide direct service units, the Centralized Intake and Emergency Services Unit, also known as CIES, and the Residential Licensing and Special Investigations Unit, known as RLSI. And finally, Central Office, and that's where leadership is located. The work in the district offices is varied and includes family services workers at the front end, conducting child abuse investigations and assessments, while RLSI generally handles investigations of regulated facilities and schools. In 2020, FSD investigations and assessments resulted in 3,618 accepted reports of child abuse and neglect. And as I mentioned this morning, the district offices also have FSWs that handle cases requiring ongoing services based on the results of child interventions. Some of the districts also have workers with caseloads limited to court-involved or juvenile justice matters. CIES is a 24/7 call center set up for intake of reports of child abuse and neglect. The unit also conducts child protection registry checks. The central office has 4 main units. The first 2 are operations and the system of care unit. Operations handles the supervision of the district directors and statewide functions. And the system of care unit essentially oversees those responsible for providing services, supports, and care for the children and youths, such as foster, kin, and residential care and adoption. The two remaining units are the Revenue Enhancement Unit and the Policy, Practice, and Performance Unit. Revenue Enhancement, it's pretty self-explanatory. They focus on the division's fiscal matters, including grants and contracts. And the Policy, Practice, and Performance Unit has a real broad area of expertise, including conducting the division's qualitative case reviews to promote a culture of continuous improvement in our practice. The statutes that govern our work are found in Title 33, Chapter 49, pertaining to child abuse and neglect, and Title 33, Chapters 51 through 53, which sets forth the court processes and procedures for CHIN's cases. Putting these governing statutes into action really boils down to the basic question of, is the child safe? And if not, what needs to be done to promote safety? So sometimes promoting safety involves bringing a child into custody. Our most current data show that 88% of the children in DCF custody are there for reasons of abuse and neglect. The children in DCF custody live in a variety of placements, including foster homes, with relatives, in pre-adoption homes, in residential care, and at home. In 2020, 32% of the children lived with kin, which is a 10% increase over last year. And that highlights the effectiveness of our diligent recruitment program, which is spearheaded by the System of Care Unit. Research has shown that kinship care may promote stability in placement, which of course result in more positive outcomes for children overall.
Deputy Commissioner, if we were to break out the 88% abuse and neglect into categories in Vermont, would we be able to look at that? So what are the types of abuse and what neglect that are occurring?
I see what you mean. I don't have that at my fingertips, but I can get that, I hope. I can ask our quality assurance unit to see if they can pull that type of data together.
Okay, that'd be terrific. Thank you.
Sure. And as I mentioned earlier, although children in custody make up the majority of the children in our caseload, FSD is also involved in children that are not in our custody, such as in conditional custody cases and family support cases. In addition to child welfare, as we discussed this morning, we're also the state's juvenile justice agency. In working with youth to promote law abidance, the division takes a rehabilitative approach and encourages youths and emerging adults to take responsibility for their actions, to make amends to those they've harmed, while still providing them with supports and services to help them along their way to productive adulthood, which is absolutely consistent with our youthful offender and Raise the Age initiatives. Are there any questions?
Ginny?
Go ahead. Go ahead. Rich,
So to follow up on what Senator Lyons' question was before, do we keep track of income levels of the family that these kids are coming out of?
I don't believe so. I can double check, but I doubt it.
I just find it interesting around that. My battered women's shelter in my county, they have the hardest time putting together living situations for somebody leaving a battered a relationship where there's abuse. Mm-hmm. And a lot of times in low-income families, they choose to go back because they don't have the resources for, and we're notoriously bad supporting reach up and supporting those things that allow them to make choices to put themselves in a better position. So, around those families, and those things have to have an effect on those kids. And so I'm just interested in what the income levels are.
I can check, but I absolutely understand what you mean in terms of your finances may dictate your choices in terms of you would like to leave an abusive situation. However, if you feel like you can't, you have nowhere else to go, you may end up back at home. And of course, as you said, then the children can be exposed to harmful behaviors. And then that can start up the whole cycle where eventually our agency may end up getting involved.
Mhm.
Does that answer your question, Senator Westman?
Well, it sounds like they don't collect it, and if they don't, it does make it harder on those families that are stressed, that would like to reach out. If you can't financially find a way to get out of a home situation, it's got to have an effect on the children in that family.
Well, it's at least something to explore.
Right. And I will check, but I wonder if that type of data is probably captured more in the Economic Services Division, where they have to have proof of income or lack of income for certain types of support.
Well, and then is there a way to cross-reference that to the kids that are in custody and in that piece? We increased in appropriations the reach up payments to families for the first time in, I think, more than a half a dozen years this year. And those payments are notoriously low, and very few of the interest groups take on supporting those payments going out. And that speaks directly to, in a family at risk, their ability to make choices to find ways out of bad situations.
I agree.
Representative Jessup has a question.
Thank you, Deputy Commissioner. There was some movement, I'm remembering at the end of last session, looking at housing challenges around youth who were in state custody. And I'm wondering if there's anything you'd care to share on that topic today.
In terms of placements, do you mean in terms of, can you give me?
Not in terms of residential placements, but rather housing was just, I'm just thinking about it when I think about Senator Westman's question about what are the various constraints at work. And we know housing across the state of Vermont is a constraint for everyone, but particularly for some of the populations that you serve. And I can't remember the thread of what, I remember Commissioner Brown testifying on that, and there was some work being done, and it was very much at startup phase, I believe, in May. And I just am curious where things might stand now. And that might be a question for another time, but I just thought I'd throw it out there.
Yeah, I'm wondering if he was testifying more to ESD than FSD, because generally our housing initiatives are more about placements and trying to find additional homes for foster care youth and things like that.
If I remember what Kimberly's referring to, it was helping to find housing for youth who were aging out of foster care.
Okay,
That's
understand.
my recollection of that.
Okay. We are still looking. We don't have an actual initiative in place right now. We are still, we were looking for housing for raise the age youths. And we are still, I know that there's another program regarding children aging out of foster care. I can't remember what town it is in, but that is through, I believe, DMH and an outside agency. So there has been some movement, but we have not started an initiative yet.
Got it. All right, thank you.
Okay, thank you. Thanks, Kelly, for filling us in. Any other questions on this report? Overview of Family Services Division. I guess the question that I continue to have and always have is, do we have the staff and the capacity to meet the needs that we're seeing in the community? And just knowing that things have dropped down during COVID, but they haven't disappeared. Can you talk about the staffing and support issue a little bit?
Yes, that staffing is a chronic issue, even more so than within FSD. We do have some staffing challenges, with really more with finding quality candidates. But the larger staffing issue throughout the state for some of our community partners makes it difficult for us because they haven't been able to find staffing such that they can continue their programs throughout the week, or sometimes having to close programs down temporarily, which of course the pressure then has a cascading effect because it makes it difficult for us to find placements for our youths. So that staffing issue does interact with our workforce in that way in particular. Internally, as far as staffing, like I said, our problem isn't as acute as others, but I have started, and I'm leading a workforce development group just to make sure that we are keeping our finger on the pulse of what our staff needs in terms of retaining our good family services workers and also giving them the supports that they need in terms of practice development, so that we keep those that we do have and then have ideas along to bring in more good quality candidates. Because I don't want it to get worse than what it is.
And just in terms of caseload for folks in the district offices, do you have an idea of what the caseload is for the family services workers?
I believe it is 16.2 per worker. So it's still a little bit higher than our mandate, but it's on a downward trend. I can pull that number up exactly and get it for you because I did do a report on caseload, and I can get that for you by the end of our session today.
Terrific. Yeah.
When you're doing that, could you also do, back a year or so ago, kids who were in conditional custody were not included in the social worker's caseload, even though they were being supervised. Is that, if that's still the case, could we also get the numbers?
Absolutely.
Because that, I know I talked to some social workers who they may show as 60, but they really have 80 to 100.
So if they're not counted, you'd like to know how many children are in conditional custody?
Yeah, you've got,
like
according to the report, the 2020 report, you had 1,105 kids in custody, 383 in the CF, and then 493 in conditional custody. Are they counted as part of the social worker's caseload? And if not, then we're not really getting a true picture of what caseloads they're what caseloads they're carrying. That's I
believe
frankly,
I believe I have that data. So what I'll do is, and I'll also send the slide deck for that presentation, but I'll pull out and tell you verbally what those numbers are as well, so you can see the whole presentation, and I'll give you specifically what you asked for too.
A few years ago, I had a foster child who was in conditional custody, and talking with a caseworker at the time, she was swamped because she had a number of kids who were in her normal caseload, but she also had a huge number in conditional custody that weren't counted as part of her case.
Okay, yeah, no, that'd be great. So what is if we were gonna look at kind of the optimal caseload, I know it's hard to say what an optimal caseload is without knowing what the cases are, but if we were gonna look at a number or a range, what would it be from your experience?
Closer to 15. Per
Closer
worker.
to what, to 50?
15 per worker.
15.
But and there's so much variance because some offices are smaller, as you know, some have their caseloads tend to be different just because of the region of the state. So it's not even just the number. There's a lot that has to do with the type of case and how many people are, children are in that family that you're working with. There's so many variables that go beyond the numbers, and that's what I've been learning and talking to the workers.
Okay.
But
Go ahead, Senator Westman.
you do have benchmarks, and you do have goals on which to meet, and they're based on and I think that would be important for Senator Lyons to have, and what those numbers are based on. It would fill in the gaps around what all of that they are.
Exactly. I wish I'd known we talked about this. I would have brought that slide deck instead, but I can get it easily. It's right on the computer.
Yeah,
Yeah,
not a problem. That'd be great. Anything else? Oh. Questions committee. All right. This is good. Is there anything that you think beyond, we've asked for a lot of additional information, which I think will be very helpful to understand where we are now, put it into the context of the organizational structure. It's very good. So unless there are other questions, we can move on to the next topic. Deputy Commissioner, was there anything else you wanted to add?
No, not at all. Actually, I see that the next is the next topic, the out-of-state placements.
Yes, ma'am.
Okay, so I do have some slides in that. So what I'll do, I thought I would be able to get you that slide deck today, but I'll include it in the other information that we collect in order to answer your questions. So you'll get all of it at the same time.
Terrific. Thank you.
Thank you.
Okay, so we'll move on to children placed out of state, judicially and non-judicially. That was the question. So Commissioner, you're on the spot again. And we have a slide deck on that, right? Okay.
Yeah, so there's a lot of company this time. I'll make sure I don't put the slide deck up until we're ready to start talking.
I'm just looking to see, I know you have a number of folks with you, and I want to make sure that we don't start before you are ready with everyone who you'd like to have before we go. But is anybody missing?
I can email Liz to see if Monica White and Diane can join.
And that would be it.
Yeah, that's good. Okay. Do you want to go ahead before they get here? Deputy Commissioner?
Well, I guess we should wait a little bit because I believe Monica has slide 5. So
Okay. Okay, we'll just be on hiatus for a minute. We don't need to go off live stream. Peggy will just be patient. Oh, Monica's here. That's good.
So we're just waiting for Diane. Hopefully she can join.
Okay. Does not pay to get ahead. Oh, are we here? That's Jennifer. So Diane is not here.
I believe we're ready to go, aren't we? Because I thought Commissioner White was going to be doing the slide that,
Oh, here she comes. Here she comes.
Hi, yeah, so I am here. Diane Bugby, our children's specialist, is also going to be joining to be able to answer any specifics that I am unable to. She is our subject matter expert and the author of the information that's contained within the testimony. So,
Thank you. Okay, so I'm going to turn it over to you all, and you know the order and how do you want to proceed? So go right ahead, and the committee may interrupt or raise their hands to ask questions along the way.
thank you very much. Can you see the first page of the slide?
Not yet, no. Do you want Peggy to help with that?
Let's see here. Might have an issue going on.
Peggy can put it up, but then you just have to tell it when to advance.
Is it right now? Can you see it?
Not yet.
Ah,
Now, let me see what I can do. Hold on. Hold on.
okay, I think I have it now.
I think that's actually me.
Was that you? Okay,
Yeah. So just if you could tell me what to do, that'd be great.
all right. Let's see.
Okay, we can see it, and we do have it on our iPads if needed, so
Okay,
go ahead.
Erica, I'm gonna start in. That's okay.
yeah,
Yeah, please introduce yourself for the record, and then we'll look forward to it.
Okay. Good afternoon, committee. For the record, I'm Jennifer Herbert, DCF Clinical Director, and I'm glad to be here today alongside others serving our Vermont youth. In the spirit of collaboration, we've coordinated our PowerPoint presentation today, so we'll be transitioning between slides throughout the presentation. Next slide, please. So as Deputy Commissioner Erica Radke mentioned in earlier testimony, the scope of service within DCF includes both child welfare and juvenile justice. And those in terms of the conversation of custody and placement, those are the categories that youth are in when they're placed. So adjudicated delinquency or youth who come into our care from abuse or neglect situations. Next slide, please. My screen is freezing a little bit. So a judge may place a youth in DCF custody because of concerns for child safety and well-being, and also in response to adjudicated delinquency and needs for supervision. And some of the notable characteristics, can everybody hear me?
Yes.
Okay. I can't see the slide, so I'll just have to go. And so conduct, some of the notable characteristics that youth may be referred to residential placement presenting need with are around in areas of conduct with aggression, conduct without aggression, self-harm, and most of the referrals that go through, and this information is coming from a resource that will be spoken about later in the slides from Public Consulting Group from 2020. That did an overview of all youth in placement throughout the Agency of Human Services. And so the majority of children referred are in DCF custody. And developmental delays are present in just about 10% of children in residential care. And most of the residential care is long-term treatment referrals. So that accounted for 62% of admissions versus assessments is at 32%. Next slide, please.
Can I interrupt, please, with just a clarifying question? Yes. With young people, what is considered a long-term placement in that slide?
So a longer term placement with youth would be a more specific treatment path. So if there was a presenting need around psychosexual issues or a particular problematic behavior that needed more intensive long-term treatment, that would be determined through an assessment at intake along with the treatment goals and with the team of treatment providers, determining that in order for there to be successful recovery and healing, that a certain amount of time to go through a treatment modality would be needed.
Is there a certain point in time where one crosses the line into what's called the long-term treatment, or is it not that? It's not a calendar-driven event?
Not necessarily. It's not a calendar-driven event. And I think that's why reassessment can be a really important component of placement, of initiating placement into a program, and also while a youth is placed in the program to determine if the treatment is effective. And there's a lot to consider. Sometimes things can get worse before they get better, so to speak. And so really teasing that out and trying to identify the progress being made in response to certain treatments and setting.
Thank you.
You're welcome. Okay, the screen is fully active again, so this is good. So because of the scope of youth and families that DCF serves, there's a lot of complexities that come with those cases. And even outside mental and behavioral health, there's environmental factors that come into play. And so the casework and the permanency and juvenile justice are areas of work within the division that are of FSD that are really important in creating recovery and outcomes, successful outcomes, so that youth can be placed in the community, which is really our main goal when it comes to residential treatment, is so that it can effectively address whatever issues we're presenting in a way that will be successful in the long term. And the comprehensive assessment and treatment services is a huge part of what can encapsulate the complexity and understanding of what might be presenting in the youth that are in our custody and what will be the appropriate level of care and for how long. And I'm going to transition into handing off to Laurel from the Department of Mental Health to talk more about the process involved in those determinations.
Good afternoon. For the record, I'm Laurel Onland. I'm the Director of the Child, Adolescent, and Family Unit at the Department of Mental Health. If you could advance to the next slide, please. Thank you. So we did want to talk about the fact that the Department for Children and Families, Family Services is one department of 3 within Agency of Human Services that does referrals for residential treatment, including out of state. And that process is actually under the Medicaid benefit and EPSCT, or early periodic screening, diagnosis and treatment mandate from the feds. And DEVA, our Department for Vermont Health Access, delegates that Medicaid authority to the different departments within AHS. So DCF Family Services, Department of Mental Health, and Developmental and Disability Services Division also all have that authority to determine medical necessity for residential treatment, including if that treatment needs to be out of state or in state. So we want to talk more broadly, not just from a particular department lens, because we approach this through a collaborative process, which is really, I would say, under the umbrella of Act 264 and our coordinated service system. So that Medicaid, the delegation of that Medicaid benefit to our departments includes, as I said, the need for working with our local teams, whoever's working with that child, youth, and family. They complete a coordinated services plan, which identifies the need for a higher level of care and a request for residential referral. That then is submitted up to the lead agency department. And then it's the department's Medicaid determination as to applying our rules for, does that youth meet the clinical criteria under Medicaid for that level of care? And then we also then hold the other elements as far as agreements and appeal rights and meeting timelines as established through Medicaid. So if it is determined by the department that basic criteria is met, then that department will bring that referral to the case review committee, which is a joint committee with representation from our departments, as well as the Agency of Education and a family advocate representative. And that's where we want to make sure that we're not competing for openings in programs, but are really taking a statewide approach to what are the needs of any Vermont youth, and how do we ensure that they're getting access to the appropriate level of care and in the appropriate setting. And so that's what the case review committee does. They review those requests, they apply some consistent criteria to make that determination, then they make a recommendation back to the lead department. But it's ultimately the department who issues that notice of decision, and then, as I said, holds any appeal and grievance process if necessary, as well as overseeing the billing process with the provider, holds the contract with the providers, et cetera. And then while the child's in placement, it's both the AHS department as well as the local team's responsibility to be following that child and family while the child's in residential, to ensure that the plan that was developed for residential treatment is appropriate for what the needs were, and that progress is being made, or reviewing what might need to be adjusted, and then supporting a discharge planning process. As we get to talk about referrals to out of state, there is this interstate compact for the placement of children, which is an additional step that we have to take only for the out of state referrals. And I think we'll talk about that a little bit later.
So Laura, I do have a question, but while you're talking about the case review committee, is that a standing committee, or are you bringing in folks who understand each of the cases being reviewed? How does that connect?
Great question. It is a fixed membership committee that meets weekly, and the lead department who received the referral for residential, I can speak for DMH. We have care managers who work with our designated mental health agencies. And if they get a referral from a designated mental health agency, they'll review that. They will talk with the team, get more information about it, and then they will bring that referral to the case review committee and present it and discuss it. And then with the family advocate there and with education there, there's discussion about, again, does this meet the need for this level of care? What programs might be most appropriate to make those referrals to? Are the educational needs likely to be met in those programs, et cetera?
Thank you.
You're welcome. I also do want to note that it's not there is sometimes a time gap between once a referral request has been approved and when that child can actually be admitted. So there are some steps that need to be taken. If there's an existing contract, that's great. Otherwise, the state needs to initiate a contract with the program. And And then, as I said, the referral process with the program, they review the referral, make a determination to accept. And if it's an out-of-state program, it's at that point of acceptance that we then need to engage this interstate compact for the placement of children. And that can take some time. So it's the responsibility of the local team, as well as working with the departments, to figure out what that interim plan is for that child to meet the needs in the meantime.
Is the interstate compact through DCF or through
So that's a
DMH?
great, thank you, Senator Sears. That's a great question, and it's a perfect segue to the next slide. And I'm going to hand it back off to DCF because it is through their process. All of the departments who make the referrals have to use the process, but DCF holds the actual process of it.
Oh, well, good. I guess I was one slide ahead of myself. Thank you.
Well, that was a great segue. As this slide, it talks about the Interstate Compact with Placement of Children, also known as the ICPC, which facilitates the placement of children and youth who meet certain criteria across state lines. As a member of the compact, Vermont follows ICPC regulations and procedures, and the compact applies to a child or youth who's under the jurisdiction of a juvenile court as part of a child protection proceeding, or has a delinquency proceeding with custody going to someone other than the child's legal parent, or is being placed for the purpose of adoption, or is being placed out of state in residential care, except for hospitals and psychiatric facilities. ICPC is very broad in its reach. It applies basically to all of the AHS departments speaking today, as well as AOE. Next slide, please.
Is it, I guess, we did hear that the bill that we have in our committee would update the compact and the compact process, but there is a compact currently in place.
That's correct.
Yeah, okay.
For the next slide, I want to just talk about some of the interesting nuances regarding ICPC when a court order is necessary to place a child in residential care. Youths in custody with an adjudicated delinquency not only require a court order, but also can't waive that right to a hearing. So that's a real extra layer of protection for those particular children. And that's different from Chin's cases, where the youth can waive their right to a hearing under certain circumstances. And if the youth objects to the placement, or, it cannot occur unless by order of the court after a hearing. And we found that many parents are surprised to learn that the right to a hearing in this circumstance actually belongs to the child. The parent only is entitled to receive notice of the hearing. Next slide. Oh.
Before we go to the next slide, don't want to be misinterpreted, but if a kid came from Massachusetts, came up here, allegedly commits a crime, does the Interstate Compact allow for that child to be returned to Massachusetts to be dealt with, or is it now Vermont's problem? And
well, now you're talking more about the ICJ process, right? Where we would be, let's say it was a crime, where there's a warrant or something like that, where we would have the child, we'd have the right to have the child detained and then sent back to their home state for.
The reason I'm asking, I heard from somebody at the Vermont State Employees Association about social workers being stuck because there has to be this hearing to send somebody to Sununu because it's out of state, and we're using it because we don't have Woodside or Newberry at this point.
Okay, all right.
That's the problem I'm actually referring to, where they wanted some change in the law to allow that, at least during this interim when we don't have our own facility and we're trying to use Sununu to not have it held up.
I
You know
see.
anything?
Okay. So yeah, no, that is the ICPC process, and those are the court-ordered hearings that we've been discussing in order to protect the child's due process rights, where there has to be a hearing and to determine whether or not such a residential placement would be appropriate for that particular child. And there is that slowdown waiting for the hearing so that the child can then, if appropriate, be moved on to Sununu. And I do believe that some of the staff have been working with the courts in order to try to speed up the process for these hearings so that there isn't that delay.
Okay. Thank you.
Next slide, please. So this is the interstate compact for juveniles, and it's different from the ICPC. This one governs movement across state lines with court-involved juveniles and youths that have run away from their home states. For FSD, the ICJ has come into play more often with the closure of Woodside. Youths that have warrants in other states that require secure placement while going through the ICJ process, they need to be placed in a secure placement before the ICJ process gets underway. For example, there were 6 out-of-state youths that were placed at the Sununu Youth Services Center through the compact to await return to their home states within this last year. Next slide, please.
So this is everything you're talking about adheres to the CHIN's requirements that are in the previous slide. So the youth over the age of 10 and the agreement by the attorney and guardian. What's the age upper limit for this group? What is the range of age that we're talking about? Between 10 and 18?
I'm not exactly sure. I believe so, but I could double check. But if we were talking about youths that were under ICJ, that were just going to be transported over to Sununu, they wouldn't need a court order for that.
Okay.
I think it's 12 to 18 is for
IT, for the J?
Yeah, I believe it's 12 to 18 to be a delinquent.
Okay.
Soon to be 19 and 20.
Okay.
So this last slide addresses the committee's question on how many children in DCF custody are currently placed in residential care and how many of those children are actually placed out of state. There are currently 119 youths in residential care, with roughly 54% of them placed in residential care outside of Vermont. As discussed this morning, under the auspices of the FFPSA, our goal is to really reduce the number of residential placements, whether out of state or in state, when appropriate, in favor of community-based services and supports in order to support the youth in our care. And now I'll turn it over to Commissioner White.
Hi, thank you. And I will say my Zoom screen has gone blank. Can you see or hear me?
We can hear you, we can see you, or a picture of you.
Okay, maybe, yeah, so I apologize, so I can't see anything. I've got a blank screen. Peggy, would I be able to jump out and jump back in? Would that be possible, just to be able to see folks?
Peggy, will that work?
Sure, you can do that if you want to jump off and then jump back on.
Okay, I will be right back in. So sorry for the technical difficulties. Hold on one second. Okay, all right. I can see a screen. Can you see and hear me?
Yes, you're fine.
Okay, great. Sorry about that. So for the record, I am Monica White, Commissioner of the Department of Disabilities, Aging, and Independent Living. Thanks for the opportunity to come in and speak to this issue. So as our slide states, our Children's Services Specialist from Dale's Developmental Disability Services Division, that's Diane Bugbee, who is our subject matter expert here. She represents Dale on the Case Review Committee, which Laurel presented an overview of a bit ago. And that committee meets weekly to discuss youth who are referred to AHS for residential placement. So for Dale, very limited numbers of youth are placed by their families through Dale. So that's a clear distinction. It's not Dale placing children, it's through their families' initiation. And our numbers are not reported due to the numbers being much less than 11, which is the threshold for data suppression for small numbers of individuals. So when youth are placed by their families through Dale, in addition to their intellectual and or developmental disabilities, other presenting challenges include significant behavioral issues, co-occurring mental health needs, and or safety issues. And the total budget-wise, the total annual payments in the most recent fiscal year for residential placement through Dale Developmental Services is just about $527,000, which is inclusive of both treatment and room and board. So that's the information from Dale as it pertains to this topic. And if there are no questions, we could go to the next hand the baton.
Yeah, no, I think there are a lot of questions embedded in the slide in terms of how determinations are made for need and for whether it's a behavioral issue, a mental health issue, and so on. But the question I will ask is, so there are fewer than 11, and the budget is a little over $500,000. So that the caseload is 11. Those are the kids who are being placed by Dale, and the cost of services for those, the room and board, is $500,000. I just want to be clear on that.
Yeah, so it's the total for the total numbers of youth who were there. And again, we can't speak to specifics. It's much less than 11, and not to be cagey, but there are the data suppression requirements in terms of confidentiality. So, but yes, the 526,754 figure is for the total cost for the individuals who have been whose families have chosen to place them out of state.
And the length of time that the kids are out of state is completely dependent upon the initial diagnosis and the treatment they're receiving.
Yes, that is accurate. And the intent is always primarily to return the individual to a home and community-based setting as soon as they are clinically able to do so. That is always first and foremost in terms of the goals for caring for these individuals. And
do we have right now, if we were to look at the kids who are in this situation, the average age or the age range for the kids who are now out of state?
I am not sure if we can speak to that with any specificity, just given the confidentiality requirements and the very, very small number that we have. So I think I will defer out of probably excess caution to speak to specifics on that, but I can find out if there is information that we can share, but I suspect we cannot because it must be suppressed.
Sure. I mean, I'm thinking about Senator Westman's question earlier about socioeconomic status of the family. And if there is a child placed out of state, then a family with some resources might be able to move or go down and visit or be close, and I don't know what that situation involves for these kids.
Right. So I'm not sure how I can speak to that without divulging things that I'm not able to share in terms of location, in terms of where those are at, and whether the families have difficulty in accessing their child because of that.
Yeah, okay.
I can say, can I address that? For the record, this is Diane Bugby, and I'm the Children's Services Specialist in the Developmental Disability Services Division. Good afternoon, everyone. I will just say, generally speaking, that out-of-state programs often have ways to engage families for which travel and engagement in their child's treatment is difficult. And I mean, that goes across all of our departments because we access the same program. So they have ways to engage families, generally speaking, whether there's a financial hardship or not. The idea is to have, when kids do go out of state, to have their families or caretakers that they'll be returning to be engaged and involved in the process throughout.
Thank you.
Thank you, Diane.
That's helpful. Go ahead.
I believe it's back to me, unless there's more with Dale. Okay.
I'm good, thank you.
Thanks. Again, Laura Olman, Department of Mental Health. I actually might have you go to the next slide and then we'll come back to this one just because of the questions. This is the ratios or the percentages of the AHS, so combined across our departments, referrals for residential or admissions for residential. The FY21 data is only through Q3 because we're in process of analyzing the full last quarter, the full year, fiscal year information. But this does give you a sense of the breakdown and the historical trend, I guess I would say, around in-state and out-of-state. Similarly, using that same Q3 data, I can say that we look at age ratios, how does it break out into age ranges? And for 0 to 12, of course, we don't have any children age 0, but 12 and under is 34%, and ages 13 to 18 were 66%. Again, across the agency. So that helps with the question that Dale's not able to answer because of the small numbers, but does give you a sense. I don't have that for all of AHS broken out into in-state or out-of-state. I do have it for DMH placements if that's of interest. But if you could go now back up to the slide above, this is specific to DMH funded residential admissions. And similarly with Dale or DDSD in their statements, the children that are funded through DMH who go to residential care are in their either parents or guardians guardianship. So they're not in DCF custody. They're not in our custody or state's custody at all. So it is a decision that the family is actually voluntarily agreeing for this referral and admission. The funding is coming through Department of Mental Health. And again, this shows the trends over the past fiscal years, inclusive of the full fiscal year for 21 here, in the breakout of youth in-state and out-of-state. What this does mean though, is it's, as we tried to note here, it's a duplicated count, meaning if there is a child who is admitted into one program and then changes and goes into another program in that same fiscal year, they're counted each time. So the numbers for in-state and out-of-state might have some duplications of children, but the total number of unduplicated children who are in residential care through Department of Mental Health for fiscal year 21 was 121 children. I hope that makes sense, the differences between those. I didn't want you to add the two columns of in-state and out-of-state. They won't add up to the 121 necessarily. And for us, that is roughly combining the Medicaid treatment costs with the room and board costs, which are not Medicaid. That's roughly about $4.4 million through Department of Mental Health last fiscal year.
So if we were to look at a plan for a child, a treatment plan, the child might be referred to an in-state program and then moved out of state and then moved back in-state, and that would be counted. That would be the duplicate counting.
Right, and the plan wouldn't necessarily be to continue to move the child. Our goals and our values, and in fact, I'll speak to this in a future slide, but are really to try to serve that child as close to their family, their home, their community as possible. And so similarly with your questions about assessment versus long-term treatment, we might start with a residential assessment. And if there are some recommendations that come out of that and they can go back into the community and have a plan of care put into place within the community, that's our ultimate goal. Sometimes a child might go with the intention for a residential assessment, and then through that process it's determined that they actually need continued treatment. And so they might continue to stay or be referred to a different program that's, if they were in an assessment program, they might need to transfer to a different program that is focused on that treatment aspect of it. For other children, they might have had an assessment in the community, and so we are looking for targeted treatment for them in a program. And there are times where the program that they start with is able to make some progress, and then there might be some difficulties, and some determinations are made as a team and with the family about whether there is a different program that could better meet that child's needs. And that would be why someone might transfer to a different program. But we really do want to try to minimize transitions. The only reason to do it is because of that medical necessity and really trying to meet the needs of that child.
Thank you. And I can see where the management of treatment in the out-of-state facility also becomes quite a juggling act as well.
I would say, COVID has some benefits, but meaning the thrust into virtual meetings has been beneficial in a way to connect families with their children in programs. That actually had been a method for what Diane was talking about earlier, how out-of-state programs can engage with families. They often do it, it's somewhat through phone, but now I think they're much more versed in doing it through a virtual platform as well. And then if a family is of a lower socioeconomic status, as you were concerned about, and if a parent is a Medicaid enrolled person as well, beneficiary as well, there are some opportunities to pursue Medicaid reimbursement for them to participate in their child's treatment in the residential program. But the parent themselves need to be a Medicaid enrollee.
Thank you. Okay.
You're welcome.
Good.
Next 2 slides forward, please. So I think we covered this a little bit. Again, just for informational purposes, not knowing how familiar the committee is with all aspects of this. We have the EPSCT mandate that requires states to provide medically necessary services for children. And then when we talk about costs related to residential care, there are different components to those costs and different sources that are covering those costs. So treatment costs are under Medicaid for the Medicaid enrolled youth. Room and board costs are through our state general fund, so each department's budgets. And then educational costs are through the Agency of Education. When a department of AHS funds a child in residential care, they're considered state-placed by the Agency of Education, and so they will cover the educational costs of those students. And to clarify, again, Agency of Education has their own separate process for residential educational placements, and that is not what we're talking about through these.
Mm-hmm.
Okay, next slide, please. I think you've heard some about why do children go out of state. Our values, again, as a system and under Act 264, is to serve children as close to home, their community as possible, and even in the community if we can. And so that's part of that determination of, is it necessary for a child to go to a residential level of care? And we take that very seriously. There are complexities of needs, and you've heard some of that. we're funded and structured in these silos of DCF and DMH and DDSD. Sorry for the acronyms. But that's not how children and families are. These are complex families. Children often might have mental health needs as well as a developmental disability or kind of borderline presentation of a developmental or intellectual disability and safety needs. And so in many of these situations, we are talking with one another, both at the state level and locally, about how best to partner together to meet these needs. And sometimes that is challenging. I think you got at it with the question of, kind of who is taking that lead if a child has those multiple presentations. And that's a process that as departments we're committed to working through together. Another reason for out of state, we don't have in-state, sorry for the acronym here, PRTFs. Those are psychiatric residential treatment facilities. That is a Medicaid designation of a type of program, which often can serve children and youth with more acute and severe presentations. And so sometimes we do need to turn to out-of-state programs to meet those. And if an out-of-state program can provide that more targeted specialized treatment that's not available in Vermont, we want to look to that because it likely could mean that they get the care they need sooner with the hope that they could then come back to Vermont. And then lastly, sometimes a program that's out of state is actually closer to a child and family's home if it's in one of the bordering states. And when we do look at the numbers, the majority of the children that we place or fund through DMH, at least out of state, are in New Hampshire and Massachusetts. Next slide. I don't know if we need to go into this. I wasn't sure if there were questions about what happens once a child is in placement, but at DMH, we do have care managers who follow that situation and then ensure that the local team is also following that, as I mentioned before, response to issues as they arise, if there are concerns about the current plan, as well as just overseeing the Medicaid and enrollment board process. So we can go to the next slide unless there are questions with that. I think some of the current challenges we're experiencing, COVID is a significant part of this, especially with children out of state. We did see, I guess I would call it a slowdown of movement. So it was difficult to both refer and have admitted children to out-of-state programs, as well as their visitations were limited quite a bit. Some programs are handling it differently now, but for a chunk of time, there were not visitations happening, either families allowed to go to the program or children going home for a period of time to prepare for discharge. And that can impact that transition planning and the feeling of readiness from the family and the child to discharge back home. Staffing vacancies is another reality, not just in Vermont, but across the country. And we're also seeing that in openings or the limitation of openings in programs. And then the acuity of children and their needs balanced with the staffing levels are of concern as well. I think that's it for that slide, unless there are any questions there.
I know, as you're going through, the question arises about whether or not we're seeing increased needs, kids' problems associated with COVID or as a result of COVID require this type of service.
I don't have data to cite for that. I can say that I know the requests for mental health care have increased.
Yeah.
I don't know that our numbers of referrals for residential have, but I think the process to find a program that can meet the needs of children is complicated right now.
Yeah.
Can I just, this may be too general a comment, but maybe with 3 different agencies of the Agency of Human Services here, you just mentioned staffing levels at both community providers and even out of state. we seem to be in a crisis, and DCF mentioned them earlier in a presentation on a different subject. Is there any plan afoot to try to deal with that? I mean, each of your agencies is dealing with this problem,
Yes.
particularly with contractors. I know my own local designated agency, for example, there were 4 clinician openings. And it just, they can't provide the services. You're running into it at DCF with placements for kids. We have a crisis here, and it's made me not, it's associated to some extent with the level of payment to the people who provide the services. For a long time, the legislature and the administration have been trying to increase the salaries, but they've been small increases, 2%, I believe, last year for mental health, local mental health workers. And I don't know what, levels we've been providing for the contractors with DCF, but other groups. But I think this is a problem that we're going to continue to face as we try to place difficult kids and try to deal with these kids. And I don't want to put it all on you guys that are here today, but I think this needs to be dealt with by the legislature as a crisis, quite frankly.
Senator Steves, I greatly appreciate your summary of that and the recognition of it. There is a workforce task force with the departments represented here, as well as Department of Health's alcohol, drug, and drug abuse programs, along with Vermont Care Partners, designated mental health agencies, to look at just that issue. They've developed a plan or have identified different areas where to try to tackle that issue, because it's multifaceted. Salaries is one aspect, and I would need our commissioner to speak to that. But there are other components as well. It's the pipeline, it's incentives to remain as well as to be recruited.
Well, hopefully the increases that we've put forward in the budget recently, and also the programs we started for scholarships and a loan repayment or payment, those things will begin to have an effect. So
that's our hope as well.
Yeah.
Well, I can only, I think it's a crisis, and I think it needs to be dealt with as such. And I appreciate all we've tried to do, both the legislature, the administration, but correction staffing of prisons is a huge problem right now. We need to face this, and I hear about all the good things we're doing. I think this is really, enough said. It's a crisis, it needs to be dealt with.
Yeah, and it is across all levels. Next slide, please. So we do try to look at the opportunities. We do have some federal funds that we are taking a look at. And thank you to the legislature for supporting a pilot for mobile response and stabilization services using some ARPA funds in one county of our state, Rutland County, that is just getting started. And there is hope to see if we can expand, as well as Vermont did submit a proposal for a state planning grant to try to look at mobile crisis services, again, across all of our departments of AHS. We are also interested in again, Dale and DMH have been collaborating quite a bit around programming for children with developmental disability and mental health needs. And there's a need around crisis services as well to support those youth. Workforce stabilization we just talked about. And then integrated care is another area that we believe can really help with access and provision of services. And that's integration of, again, speaking from mental health care in early care and learning settings, within schools, the integration of mental health with primary care. And we have some opportunities underway to work on all of those. And then lastly, very quickly, I don't need to spend time on this at all, but wanted you to have the link. We did have an assessment of the children's residential system of care. So there was an external contractor, public consulting group, who worked with our agencies, agency departments, as well as Agency of Education and the provider system, family advocates, and family and youth themselves. Gathered a lot of information. I apologize. And put together a final report with some recommendations, and you can see that there. And that is something that the state interagency team, again, representative of our different departments and AOE and family advocates, is looking at how do we really dive into some of that and try to put forward some of those recommendations. And now I'll turn it over to Jennifer Herbert.
Thanks, Laurel. And so we're going to end the presentation just with how the day started. Families First Prevention Services Act, as that will, stemming from Laurel's last slide, is a lot of the work is in the same areas, integrating services, community resources, access to evidence-based services outside of a residential setting, and creating funding streams that are going to be more in the direction of the preventative services and along that end of the continuum, with hopes of treating youth who may come into our care in the community as much as we possibly can. And it's a law that promotes integration among agencies, and it really lays groundwork for intra-agency coordination as well, which is important across the board. Any questions? That is our presentation.
Well, that's wonderful. Thank you. It's been a terrific presentation. And we've really gotten our heads down on boots on the ground a little bit. And we greatly appreciate the time that you've each taken to bring this information to us. Very much so. Questions, committee? Representative
I have
Joseph.
a question. It may not be exactly the right fit for today. I'm looking at the slide that says DCF Family Services Division, youth currently placed in residential care. And I thought I heard in the mention of DMH's placements, 121 kids, that it was around 4.4 million. And I'm wondering what the scope of dollars associated with some of these categories might be. And I don't expect everyone to have that today, but that obviously was a very big discussion in the legislature when it came to the Newberry and the closure of Woodside. And there were various numbers that I expect probably are being updated or moving along. And I would be curious where those conversations stand.
If I may jump in before talking about the dollars, just the DCF numbers are youth currently in placement, and the DMH numbers were the total youth in the fiscal year. So those are different measurements.
Okay. Any other questions?
I didn't know if it was the dollar amount question for DCF, or were you asking that of all of us?
I'm asking for DCF.
I'm trying to understand, is the question in terms of how much generally is spent on a child, or just in general in a year for residential treatment?
Well, I guess when I look at a chart like this, I'm trying to translate it into some of the lenses that we are faced with here in the legislature. And that kind of goes back to my question of what's long-term treatment. For better or worse, we operate in fiscal years, and we operate, as I'll do all of you, with budgets attached to those. And so when I look at a chart like this, there's been so much conversation about in and out of state placements, and I just don't have a sense of what kind of resources we're talking about. And I also don't have a sense if when the Newberry facility comes online, would that be a piece of this chart going away? I'm trying to match what I'm looking at in this presentation with the current events in Newberry, as well as the fiscal conversations that we've had both last year and that we will have in December in budget adjustment, which is not very far. And that's just kind of a lens that may not fit right now in these discussions, but it's one that I'm thinking of.
Understood.
And
I'm
also
thinking-
think some of it's Medicaid dollars, some of it's AOE dollars, some of it's DCF dollars, Dale dollars, so mental health. So it's a complicated appropriations picture, I would think.
Yeah, I agree. That's probably why the chart ended up being more per child in-state and out-of-state. We might be able to sort of do a comparison from one year to the next in terms of spending in-state and out-of-state. And in terms of Newberry, some of those children would be able to be placed there. Newberry is going to be more of a stabilization, crisis stabilization, more of a short-term type of placement, but that is occasionally appropriate for residential treatment as well. And it's absolutely geared toward treatment. Jennifer, do you have anything to add to that?
No, I don't have any additional information.
See, the more we learn, the more questions we have. So you've educated us well. So now we take the next step. Any other questions, committee? Terrific. Okay. Again, listen, thank you all. This has been very informative and extremely helpful. Of course, the devil is in the details of how much it costs and what the diagnosis is for each kid and where they're going. I mean, it's a complex juggling act that you have in front of you. And we're really appreciative of the work that's going on at DCF, at Dale, and at Department of Mental Health. You're all very, very busy, and we appreciate that. And COVID has made it but worse. I can't imagine trying to help these families during the time of COVID. That really can't. Difficult. So unless there are other questions or comments any of you would like to make? Okay.
I was only going to say credit goes to the providers. So thank you.
Yeah, it's great. So we'll move on to committee discussion for a few minutes. And again, just to say thank you to each one of you for being here. Very much appreciate it. And Deputy Commissioner Radke, you've earned your pay today. This has been a long day.
It was a pleasure to be here, and I'm going to keep a little clip of that for Commissioner Brown.
Okay. All right, good. All right, so terrific. So we're going to go into committee discussion. You're welcome to stay and listen, but it could be extremely boring.
I'm heading out. Thank you all. Stay cool this weekend. Take care, and I'm sure I'll see you soon. Bye.
Okay.
Thank you.
Thank you.
Thank you all very much.
Thank you. Goodbye.
All right. So committee, we've got we've identified some things that we want to follow up on. And we also have Peggy, do we have a list of our I know it's on my computer at home, it's easy to access, but it isn't as easy on my iPad. Our topics coming up in our next sets of meetings. I know we had
We
current
did.
patent,
Let me see if I can find it in my email too. I think I have it. Hold on.
yes. Okay.
A minute for it.
But I think in terms of committee, in terms of following up with this, we are going to want to have the Family First plan come into us before it's packaged and sent out. I don't know who made that comment, but you're right on target. So that would be September. we would want to see that or just before it goes out. Dick, did you want to add something?
Well, only the judicial review. I think it's impossible to see this going forward without some hearing from the judiciary about how they're going to accommodate
All right.
the new, I mean, this is like a new duty for them.
So we should actually, in September, we should probably put, I forget the dates that we have for September coming up, but we'll try to sort out.
The next meeting is October 1st.
It is, okay, so we should see the plan before it gets sent out. And then we can look at it together on October 1st. And regardless of whether it goes out or not, we should have an opportunity to weigh in on it. And at that meeting, we should also then have Judge Grierson in to talk about the 60-day judicial assessment. We may also want to talk about the 30-day period for AHS, just to get our arms around some of the plan. So that's definitely on the agenda. And then I'm open to listening to you about whether you'd like to dive into Kern-Hatton. It probably makes sense to do that since it'll take some time both for DCF and I don't know, we're going to have to dive into that a little bit. And then the Newberry facility. And the Newberry facility in Kern-Hatton may spill out over into our October, November meeting times as well.
Yeah, the Kern-Hatton issues, particularly there was a failure to report by mandated reporters when they were under DCF. And I can't imagine that it will improve now that they're not under DCF, and that and I don't know that AOE is even what their involvement is with Kern-Hatton.
Well, I guess the contextual question is what facilities have we got, residential children's care facilities have we got in the state? And what happens when a facility like Kern-Hatton does not have any link with the state? So licensure. So we need to go through all of that. You're absolutely right.
There's an awful lot of small independent schools around the state that I'm not sure are under much.
Yeah, we're going to be crossing the line into education, but we'll try and look at a little bit of both.
And the Kern-Hatton is its own issues.
I'm thinking we should probably spend one full meeting just on Kern-Hatton. And I think the Newberry facility, we could probably put into the next meeting along with a review of the Family First plan. So we'll think about that.
I don't think there's going to be much new on Newberry until.
Yeah. All right,
actually, what would be interesting to know is what they need in order to, while we're waiting for Newberry to come online, if it actually ever does, what do they need in the interim? And also, do they have legislation in the plan to try to deal with some of these problems?
Okay, that's a good question.
And I did bring up the issue of the crisis in staffing for the.
No, I think
what do they have planned for that?
Yeah, that's the big question, because the staffing really helps determine the programming that's available for the kids who are there.
We put all that money into after-school programs, and the cannabis money is supposed to go to summer school programs.
Yeah.
And they can't even hire people for after-school programs in our area.
Yeah.
I don't know if it was in the banner, as if the banner is the the know-all, but I mean, they had a list of job openings for after-school programs in the North Shire, which is Manchester and the mountains, basically.
Yeah.
Astounding.
Okay, and then we should pick up the Chin's report. Maybe we can do that next time when Judge Grierson is in. And then we're also talking with the Joint Justice Oversight Committee about a report on foster care that is coming out of UVM. And so when we meet in November, I sent a note to Representative Emmons, and I think I copied you, Senator Sears, on that.
Thank you.
And Ann Pugh, so that we could hear the UVM research report. It looked very good. The preliminary report looked really very good. So we'll have to communicate again with Alice Emmons and see if we can get a joint meeting with them. So that would be a joint meeting in November for at least part of the time. So we have plenty of things to keep us busy, and we have a lot to learn. So we'll do that. In terms of the Office of Child Advocate, I think that we decided to leave to the legislative process, because there is currently a bill and it's in the Senate Health and Welfare Committee. So we'll be able to pick that up for full discussion during the session.
So what did we decide on for the next meeting?
So for the next meeting, we're going to ask Judge Grierson in.
Yep.
We're going to ask questions about the 60-day judicial assessment that is included in the plan, the Family First Plan. And then we should also get the Chin's report information, and Senator Sears can help us guide the direction for that. And then we are also going to be looking at the Family First Plan that the department or the agency will be sending out.
Yep. And what else?
Was there anything else we said for the next meeting?
So, Ginny, Senator Lyon,
Yes.
so are you planning with Kern Hatton doing a whole day?
I think it's going to take some time.
I was just thinking that it would be my preference to have a presentation on Kern Hatton, and then in a separate meeting, a second one, come back, because some of the issues around Kern Hatton are going to be difficult given their history. And I just would rather it was broken up. I'm fine if you do it in one day, but I want to hear some of the story and some of the pieces in the front, and then move into what we think might be the recommendations for oversight after I've had a chance to think about it.
Okay.
Does that make sense?
Yeah, it does a little bit. We will, let me think about the best way to do that. And
yeah, I
hear you. It might be helpful to have DCF come in and talk about the licensure process, and AOE to come in and talk about the certification process.
Yes.
And then what it means not to have those, and then we'll take, and that would be just the introduction, and then go to the next meeting with that.
Right. I have to say, given the history and all of that, it's disturbing that they're not regulated.
Yes, I think there's a lot of agreement around that. So, thank you for suggesting that. Well,
Can I suggest that we also get, and Peggy has her address, the lawyer,
Tim Doherty?
Kim Doherty.
yes,
Give us an update of where the lawsuit is and the numbers and et cetera.
yeah, that will
Their
take more
perspective
time.
at the same meeting, then if I think she would be helpful to hear from, as well as AOE and DCF.
Okay. All right, well, so we'll have to sort out how much we're putting into a single meeting. We'll have to divide
Yeah.
some of this up. But Peggy, do you have all of that?
So for the next meeting, I have Grierson, the CHIN's, the 60-day thing, the 30-day thing, Family First. We want to have, see the report from the agency, and then we want to, in specifically with Kern-Hatton, we want to talk to AOE and DCF about the licensing process and certification process, and what does it mean not to have them, and also an update on Kern-Hatton from Kim Doherty.
Right, so I'm thinking that meeting just went really long, so we'll have to sort out what we can and cannot do.
Right.
Next meeting. But this is helpful. And then, is there anything else that you folks, committee members, would like to have on our list of topics?
It's not a list, but does anybody have to be in the State House to have our next meeting?
Okay, so Peggy, let's go off YouTube now. We can work on